What do you think can be done to get opioids away from doctors who overprescribe?
First of all, I'm not sure that doctors overprescribe. The assumption that doctors overprescribe. When you have a dependent patient, he needs opiates. There's nothing you can do about it because this is an illness that was developed by exposure to opiates. Now, there's a lot of misunderstandings in this issue. Doesn't matter why somebody starts using opiates, which is a very effective and very good medication with very little side effects. I mean, the main side effect is the dependency itself. But the problem is that dependency is not being perceived as a dependency, but much more as an addiction. So this is an issue that was pulled out from mainstream medicine. Therefore, the remedies available, they just deal with the secondary effects of the primary illness. Therefore, we have a crisis. So the problem is not on the prescriptions. The problem is not on the big pharma producing opiates. Pretty much the problem is the academic world has failed in this field for over 60 years, not bringing up any developments, any achievements on the level of care. So, I found it peculiar and interesting that nobody's pointing the finger to the real source of the epidemic, which is the academic world. How come this field of medicine has no evolution, no developments for over 60 years? So blaming the doctors and blaming the big pharma is just missing the point. And the results, the outcome of this epidemic or crisis, will be chaotic if people don't switch their thinking to where the problem really is.
So then, if that's the case, why don't more people know about it?
It's a very simple thing. In the 60s, 50s, 60s, when opiate dependency became a social event, the technology was not there to really understand the events that happened on the receptor level, on the brain. And therefore, remedies came isolating patients from society and then replacement of street opiates into pharmaceutical opiates to try to control the patients. Now, the problem became worse and worse. Therefore, more funds were channeled into those directions. And once you are invested, you become committed. Now, imagine 50 years, 60 years doing that. Today, you have billions of dollars invested on treating on those remedies. And unfortunately, as I said before, this issue was pulled out from mainstream medicine. And, everything is based on theories. You see all the expert people that they give opinions in these courtrooms against the big pharma. There's a very little science there. A lot of perceptions, a lot of opinions, a lot of almost like a mystic thing that nobody really puts the finger there. In medicine, the physicians who agonize and antagonize, who are playing with those receptors, are anesthesiologists and critical care physicians. With that, who are treating those patients are psychiatrists, social workers, and psychologists. So you understand there's a big gap here. It's the only field in medicine that for 60 years nothing has changed. It's the same level of care. And that's the roots of the epidemic. It's not a bug that came from outer space. It is our failure to provide the patients with effective, safe, and humane treatment.
Yeah, that's the first time I've ever heard anyone say something like that. So, so then, what do you think the federal government can do to help mitigate the crisis?
First of all, if we know that the available treatments are not appealing enough for patients, because most of the patients, they wake up every day in the morning nauseated with pain. With that, they are not reaching out for help. So the first failure of the system is not having a treatment that will be appealing for the patients, that they don't want to be like that. Most addicts I met, they try and try and try again and again and again. So they want to be well. And the second challenge is to provide an effective treatment. I have treated over 24,000 patients in Switzerland and in Israel, like Europe in Israel. And I believe that my contribution was allocating, defining, identifying the biological roots of the problem. Doesn't matter if you use opiates because you have pain or because you want to feel high. It's the same medical event. So a newborn receives opiates from the pregnant mother, and when he's born, he'll be born with a dependency. In America, every 15 minutes you have a newborn like that, and there's no remedies and no treatments to reverse the dependency. So those newborns are given opiates, and so they don't have a severe withdrawal syndrome and die. And then we'll take a month and a half, sometimes 2 months to have them, to wean them off of the opiates with severe brain damage. A newborn like that could have the dependency reversed in 15 minutes to 30 minutes with the proper treatment. So that's the problem. And the same with everybody else. Nobody that starts using opiates intended to become dependent, or they wanted to feel high, or they wanted pain relief. But once they are caught in the dependency, there's no way out. So they learn how to become somebody else. So doctors, they have to prescribe because patients are asking for it, not asking because they want to feel high. The people who are using opiates, 99.99%, is not people that they just want to feel high, are dependent people, like a diabetic patient depends on insulin, they depend on opiates, what they can do. So as long as we don't have an effective, safe, and humane way out, the chaotic epidemic will become worse and worse and worse. It doesn't matter how much money they put into the system, because the money is going to treat the secondary effects of the primary illness, which won't help.
Mm-hmm. Very interesting. So
yes, it is. It's tragic, but it's interesting.
Yeah. And also there's been stories in the news about people getting their wisdom teeth removed who might, after the surgery, take opioids to alleviate the pain. Would there be another alternative that would provide some kind of relief that would be better?
Opiates are an excellent medication. Now imagine, if you use more opiates during anesthesia, it will require less anesthetic agents, which will have less pharmaceuticals to be metabolized in the liver, so the patients will recover faster. If you give more opiates during hospitalization of patients from all kinds of reasons, the patients will feel better at the hospital. Now, when somebody develops a dependency in a hospital because they were given opiates for 3 weeks, to reverse that dependency will take a whole hour, not more than that. But that's the problem. So if you ask me, opiates are being underused, not overused. Doctors are afraid to give opiates, and therefore they are not doing good medicine. You could give much more relief for patients if you use more opiates on hospitalized patients. But you must know how to reverse if you create a dependency. So being afraid of creating a dependency because nobody knows how to deal with the dependency prevent doctors from giving opiates to patients when they need opiates, which is bad medicine. So, it's so profound, the changes that will happen once the dependency problem will be inside of the heart of good medicine, which is not. Who is treating opiate-dependent patients? Rehab centers, detox centers, super detox centers, and that's not the problem. The dependency is not, to treat a dependency is not to detoxify a patient. It's to neuroregulate, to modulate the ratio between endorphins and receptors, again, that was broken with the dependency. That's the issue.
And I've heard you say a couple of times that reversing the dependency could take a brief amount of time. How would you do it?
Okay, I'm treating patients now that they are dependent for 20 years. So the hardcore patients, it takes a day and a half of hospitalization with like 4 hours that I use some anesthetic agents to allow patients to go through the process in a comfortable way. So the idea is that when the dependency is established, means that the endorphin receptor ratio system is broken, because we produce micrograms of the endorphins, you use milligrams of opiates, the body starts producing normally endorphins, and then you become dependent on the external kind of endorphins, which is opiates. Endorphins, you see the name endomorphin, is a natural opiate. So this is the first leg of the dependency. The second one will be that because we produce micrograms of endorphins, we have accordingly amount of receptors. Once you bombarded your brain with milligrams of opiates, your body produces more receptors. Therefore, after 2-3 months, the patient feels that the amount that was okay for him 3 months ago is not okay anymore. They need more. So they use more and they make more receptors until eventually they die because the amount they think they need will be the amount that will kill them. So what they do, the objective of my treatment is to reestablish a normal balance between endorphins and receptors. So I hospitalize the patients. When I put them to sleep, I start cleaning opioid receptors with a medication, which is antagonist that washes opiates out of the brain. So the whole withdrawal syndrome, instead of happening upon 2-3 weeks, will happen in 4 or 5 hours at the most. And then I control the withdrawal syndrome in an intensive care facility, and I block enough, but I don't block all the receptors. So I have to allow open receptors so endorphins can reach the. So I stimulate endorphins, I block receptors, and I reestablish a normal balance. The patient sleeps through the night. The next morning, they are free from the dependency. And the great thing is that people go for all kinds of treatments. At the end, they can overcome the withdrawal, some, but they will feel bad. They will feel unright, and they will relapse. Why? Because endorphins are diluted in a huge amount of receptors. So every recovering addict, he cannot enjoy the benefits of his own endorphins. Therefore, they will relapse. So my patients, I don't need to teach them how to live their lives because endorphins, they are antidepressant, naturally, anti-anxiety, painkillers, mood stabilizators, sleeping pattern stabilizators. So once you have a good level of endorphin in your brain, you feel okay. And I don't have to tell you, don't do this, don't do that, life is beautiful, be strong. They don't have to fight against anything. And that's the issue. Good medicine changes the psychological status and performance of the patient without long-term, expensive, not useful rehabilitation, whatever. So it's changing completely the paradigm of treatments for opioid dependency. But it's not Dr. Wiseman. It's just what is written in textbooks of medicine. So the key of all your questions, allow human beings to be treated as human beings. Take away all the pre-existing misconceptions and moral prejudice and investments and all that. Yes, everybody is deeply invested on what exists, and it's very difficult to change directions to something that will be much cheaper than anything else. Do you understand? If you ask me, more budget to this field, I say, no, the opposite. There's too much money in this field. So when the federal government allows more billions to this field because we have a crisis, they're not helping anything. We have to change directions. And with a fraction of the money being used today, you can have results 10 times better.
Wow. So,
yeah.
All right. Thank you for your time. Can I just have you clarify your title, please?
I'm Dr. Andrea Waismann. I am the developer and the medical director of the ANR clinics.
Of what clinic, sorry?
I have a clinic in Israel, in Switzerland, and in Naples, Florida. Our office is Tampa, Florida. I'm here to teach and to pass my experience over. That's the goal. It's not a business venture. I'm here to share my knowledge and my experience with fellow American colleagues and to try to change the perception of this issue because I've been very lonely for 30 years. It's like that a jumbo plane will crash, why, and nobody's listening to you. And that's what happens in America every day. A jumbo plane is crashing.
All right. Well, thanks so much for your time. I appreciate it.
You're welcome. You're welcome.
Take care.
God bless. Bye-bye.